Good evening, everybody. Thank you for joining us again. My name is Samer Abduri from Muscat Endoscopy Academy. And today we're doing the second part of our three-part series with my good friend Bassel Duwaji, who's an application specialist and a guru for reading manometries and pH monitors. And we've had a very good feedback and response from some of our viewers to the first episode where we spoke about the concepts of manometry in general. And today we're going to get into the nitty-gritty details of this. So today we'll move from what a normal manometry study looks like to the equipment, technique, and data interpretation behind it. So understanding the machine and the key parameters like that we spoke about last time, which is DCI, Distal Contractile Integral, IRP, Integrated Relaxation Pressure, DL, Distal Latency. These are the things that we spoke about. These are very essential to understand before interpreting the complex tracings in the machine. So, Basa, before we go into numbers, can you give us a quick overview of what a manometry system looks like and what its main components are?
Yes, good evening, Dr. Simon. And thank you again for this webinar. Actually, I'd like just to highlight some, let's say, technical points on the system, the machines, how it look like, because maybe I believe that many physicians or doctors, they don't know exactly how the machines look like. They only see everywhere the reports only, or receiving reports from the other physicians, but maybe they don't know exactly how the machine look like, how the procedure done. So I would like to share some points that we have to understand very well to know exactly how it's the procedure done. Because as much as the physician understand more in details how is the procedure, he will be more able to have the right and the correct reading for the report in the futures, and to avoid any misunderstanding or misinterpretation, or maybe sometimes it's some points that I are going to explain. It will, if it's not done correctly, the result will be wrong. So today I think it will be 45 minutes, I hope. So, but I will be, I think it will be very easy, simple information, but it will be very useful.
Very good, very good. So, as far as I understand that, like as we spoke about this a little bit beforehand, you said that what you would like to do first is to show some things today, right? You're going to be sharing some photos and some images. I think the first thing that you would want to show maybe the components of the system, right? Like the catheter, the
Yes, yes,
interface unit, the
yes,
software, and
exactly.
all of that. So,
Yes.
would you like to start by sharing something, or would you like to speak about it?
I will share the presentation PowerPoint, everything in this presentation. I will start. Can you see my screen? It's okay?
Perfect. Yes, it's great. Thank you.
Okay, so uh, um, first of all, I just want to share this is like simple explanation about the machine, the systems. Actually, we have two type of the machines. We have a machine, it's based on the water perfusion, and we have another type, it's called solid state. Why I put it in the presentation, and I want to just to mention these important points, because in sometimes you can read in some reference numbers that this normal numbers it's based on solid state, and this reference number is based on water perfusion. Most probably now recently it's maybe they have the reference number, for example, let's say for IRB, it is for both, it's cover both solid state or water perfusion. But during maybe if you are reading some literatures or guidebooks, you can see that there is solid state and there is water perfusion. So this one on the top right, this is the water perfusion system. In water perfusion system, you find that there is a lot of sensor pressures And in solid state, there is only the catheters. That again on this side, on the left bottom, this is the water perfusion sensor, and this is the catheters. This is the catheters. It could be 20 channels, it could be 24 channels, could be 22 channels. It depends on the type. Each channel here, it's connected to this blue pressure sensor. Okay.
Mm,
And each sensor is connected to this module. Then this module is connected to the BC.
mm,
And the water, it's through a pump. It's go through the tubings, then through the sensor, the pressure transducer, the blue one, then to the catheters, then to the end. There is this very, very teeny holes that the water going out from it.
mm,
Okay. So this is the type of water perfusion. It's the catheter is made from silicone. We have two type. We have one it's reusable, and we have also single use. For usually for the esophagus manometry, it's usually we are using the reusable one. The single use, it's usually used for the anorectal manometry.
mm, mm,
In solid state, we have these catheters. In solid state, we have a catheters. There is no water, no pump, no tubing. Why? Because this catheters it is has like a electric sensors.
mm.
Most of the catheters is 36 channels, and for sure
Oh,
it's reusable. There is no single use solid state. Okay,
mm,
so I believe that solid state it's more easier to use, but it's more expensive. It is like just here I can see that there is some brief comparison between the solid state and the water perfusion. In the response time, the solid state it's faster than the water perfusion. The portability solid state it's higher because we have only these catheters. For calibration, so it's more easier to do calibration because there is no water going inside the catheters. There is no bubble to make plug inside the channels. But the solid state it's much more expensive comparing with the water perfusion. I am talking here about the catheters itself. Uh, we can say that in USA, most of the system is solid state. In Europe, like 70% solid state. In Middle East, like say 50-50.
mm.
So it depends on the schools of using manometry.
Okay.
So
Mm.
we have solid state and we have water perfusion catheters. Okay.
Okay. So in terms of if we just like to always try to repeat what um the things that you have described just to fully make sure that I've grasped everything that you have explained so far, and so that you can also follow up if anything that is inconsistent. So what we are talking about here in general, that when we have this system that we have, it's three things that we're dealing with. We have the catheters, like the different types that we were talking about, but then we have the interface unit. That's the thing that converts whatever analog signal to digital data. And then we have the software that
Yes.
shows us the topography, right? And then we go and talk about um, the types of catheters. And as far as I understand, there's like solid state catheters. It is what is the main, the corner, like I mean, the golden standard now, and it contains built-in microsensors. There's no need for external pump, and it's faster response and better resolution. The
Yes.
water perfusion is more economical, but it's slower. You can get some artifacts
Yes.
from bubbles and whatnot. And if you
Exactly.
want detailed motility or rapid events, like what you should go for is the solid state catheter. It gives you more
Yes.
precise real time data. Is that fair to say?
Yes. No, that's totally right. What you mentioned. This is the
Right.
summary for the difference between the solid state and water perfusion.
Okay. Okay. Great. All right.
Okay.
So, if we were to Now to move on, like to the idea of calibration and setup, unless you had something specific here in mind. I was meant to ask you about like, I mean, the calibration stage. I mean, inaccurate calibration or inaccurate zeroing can make a normal study look abnormal. Is that something that we should talk about first, or do you think first we should talk about the position of the patient?
Yes, because the position is also it's very important for to how to start the procedure.
Okay. Okay. Go
Um,
ahead.
and in general, usually we are make the insertion for the probe in the upright position. Okay, it's now all the talks now will be for both type. The insertion will be in the upright position. It is from the nose. It is almost the same for the inserting the NG tube. Then after we insert the probe, then we ask the patient to be in supine position.
Mhm.
Why in supine position? Because it's as the per the protocol, the investigation protocol, it's done based on the this position to be in supine position. And
Mhm.
for sure, before once the patient come, he has to be prepared well, very well. He has to be fast for at least like 8 hours. We have to explain the procedure for the patient. I think we mentioned this last time, but it's very
Mhm.
important again to explain to the patient what is the procedure, and
Mhm.
also we have to explain how we are going to insert the catheters from the nose to the stomach, and what is his what he will going to feel during the insertion.
Yes.
At the end, it's not painful. It is a little bit. It's annoying. It's not easy, to be honest with you. But at the end, it's not that painful. So the patient he has to understand these points to be more cooperative with the nurse during the insertion. And it's very important also to let the patient follow the instruction during the procedure. And again, the most difficult part for the patient, it is once the catheters passed through the pharynx. Once it's past this area, everything will be easy. I mean, drinking water with the catheter inserted, it is something it's very normal. There is no pains because most of the patient asking how I will put the catheters and then I will drink the water. You always assure to the patient that don't worry. Once the catheters in the right position reach to the stomach, everything will be okay.
Yeah.
This is the main point. And then once we want to insert, we can or use lubricant
Mhm.
to make it more easier on the
Mhm.
nose. Um, there is some doctor they are using spray, anesthesia spray, or even
Yeah.
gel.
Mhm.
We can use it, but we should be very careful about this one. It should be a very little amount using spray or gel, because we don't want to have anything affect the motility or swallowing, because we are
Mhm.
going to give patient to drink water during the procedure. So
Yeah.
if there is any anesthesia that affect the swallowing, maybe it will make aspiration. So I do prefer firstly to try to insert without anesthesia, without any spray, just lubricant gel.
Yeah.
And from my experience, that 98% it's done without anesthesia, just by lubricant gel.
Yeah. Yeah.
Uh, After we insert the catheters, we have to wait for 1 or 2 minutes for the patient to be comfortable, to adapt his position, to adapt that the catheters is in his nose and in his mouth.
Mhm.
Then we have to record the baseline pressure.
Right. Right.
Then
Mhm.
we can start, yes, then we can start the protocol. It's protocol. I mean, we should give the patient 10 wet swallow. Each swallow it's 5 ml,
Mhm.
and we have to wait. the interval between each swallow for 30 seconds.
Mm.
Uh, if we have a case of achalasia, for example, no need to wait for 30 seconds because there is no peristalsis. Usually we are waiting for 30 seconds for
Mm.
the progression of the swallow to be completed. But if we have achalasia case, there is no peristalsis, no contraction. We can see the pan-esophageal pressurization immediately. So we can give after like 15 seconds, we can start to give the patient the second swallow. But anyway,
Mm.
it's better always to keep 30 seconds between each swallow. And
Mm.
the first step should be done by wet swallow. And we can also give the patient viscous or solid swallow. It depends on the case. Then we can see what is the real-time pressure topography. This is the good things for the manometry that we are seeing the pressure in the real time.
Mm.
And I will show you in the next slide how it will look like during the insertion. Then once we finish the protocols, we have to remove the catheter gently. Then if it's reusable catheters, we have to start immediately cleaning and disinfecting as per the protocol from the manufacturer of the catheter itself.
Right.
In this the next slide, I think it will be very interesting to see how the catheters it will be look like during the insertion. This is in the real time.
Right.
Again, once I have, as I mentioned last time, we have three zones. We have the upper high pressure zone, which is the UES, and we have the lower pressure zone, which is the LES, and we have the body of esophagus. During the insertion, the real-time topography it will be sorry, it will be like this. I start inserting the catheters. Now this is the realization because of the insertion of the swallowing from the patient.
Mm.
Then now I have to watch this zone, the upper high pressure zone, the UES. I have to see that this pressure is start to be in between these two lines. And also we should have high pressure in this area. Once that we are seeing that there is the high pressure here and high pressure here, then we
Yeah.
can press to start recording. So I should have the high pressure zone and also the lower high pressure zone, the LES. Then I can start recording. I mean, everything I am doing before during the insertion, there is no recording.
Yeah.
Okay. And then I can start to give the patient the wet swallow, each swallow that it's 5 ml. And
Mm.
then you can see here, once the patient start to swallow, here we will see the relaxation of the UES, and this is the normal, for sure to see the normal swallow.
Mm.
So this is
Mm.
how it will look like. It's in the real time. Okay,
Mm.
it's very
Mm.
simple.
Mm.
It's simple now because
Yeah.
it's normal
But
swallow.
that thing that you showed right before, like as
Yes,
the patient was swallowing the, if you go back please, as the patient was swallowing the catheter like through the
catheters.
nose. Yeah.
Yes,
So is that, and that's when you said you start recording the resting pressure, is that the same as the calibration phase or not?
okay. Good question. No, actually, the calibration it's done before the inserting the catheters. Maybe
So when
next
you
time I will talk
when it's
about the
still when it's
calibration.
inside that little bowl.
Yes, and there is two type of the calibrations. Almost it's done for the water perfusion. In the water perfusion,
State.
we
Let's talk
have
about the solid
to
state because I think, sorry because I think solid state
yes,
is the thing that is the most common thing, and I think I mean, the
It's
thing
more
that
easier.
even easier, and I think what people are usually used to doing, and I think once we kind of venture into that water perfusion stuff, I think a lot of physicians, at least myself, I would right away hand it over to a technician that works only with that, because then it just becomes so
Yes.
difficult. But if we stick to the water perfusion, to the solid state
Third
catheter,
state.
before
Yes.
before I put it inside the patient, do I do anything before I put some, like, any just
Yes.
lubricant
Yes.
jelly on
Yes.
it, or can I just
Yes.
go right in?
Good question. By the way, this is what we are seeing here. It's solid state catheters. Okay. You can see here there is zero all bottom. It's very simple in solid state. We just have to put or to hold the catheters with the sensor exposed to the atmosphere and then press zero all. That's all. Then
You put
the
the
calibration done
atmosphere.
for the catheter.
What does it mean? Like, just hold it like
And
this? Does it mean like just hold it like
yes,
this, or what is
exactly.
it? Yeah. Okay.
Yes. So this is the support. This is the catheters. This is from it's connected to the system, and I hold from the end. And but
Yeah.
I have to make sure that I am not pressing on any sensor because there is sensor on the catheters. So I have to
Yeah.
make sure that I am not holding or not pressing or not catching the catheters from on the sensor itself. So suppose this is there is sensors here, 36 sensors. I hold from here, for example, and I hold from here, exposed to the atmosphere, and at the same time, I have to press zero all. If I am holding it myself, I will ask someone else to help me press zero all. Once I press zero all the values, all the readings on the screen, it will be back to zero. So this is the calibration for the solid state. It's very easy and it should be done before each procedure. It should be done before each procedure. From time to time, it's like 6 months or 8 months or 1 year. It's depending on the load of the on the catheters. We have another type of calibration. It's more technical. It should be done by service team. But before each procedure, it's very easy. Just holding the catheters, then press zero all, it will be okay.
Okay.
So how I will know that it's
Yeah.
everything's okay? If I did the calibration, how I will know that calibration done correctly? Once I press zero all, so all the reading on the screen, it should be zero. I mean, it will be, you can see here the scale, we will know it by the color. If it is zero, it should be like it's a little bit dark blue. So all the lines will be dark blue. If there is a problem in any sensor,
Mm.
you will see that there is a continuous line.
Mm.
It's not changing. That means this sensor, it's not reading any changes in the pressure. That means this sensor, it's broken.
Okay.
Or
Okay. Okay.
maybe it's need more technical calibration.
Right.
Okay.
Makes
This is
sense.
very, very rare. It's happened only if like the catheters fall down on the ground or for any kinking strongly. It's
Yeah.
like this. But also we have in this case, we have another question. If I did the calibration and I found there is one sensor, it's not working, shall I stop the procedure or I can continue? Actually, it's depending on the position of this sensor. And as we have 36 channel, the
Yeah.
distance between each sensor, it will be 1 centimeters.
Right. Right.
Okay. If this sensor, for example, in the middle or in the upper part, only one sensor, so we can continue, no problem. Okay. Why? Because once we finish, when we want to start doing the analyzing, I can deactivate this sensor and the software automatically will make averaging between the sensor before this broken sensor and the one after this broken sensor. I can do
Exactly.
this if I notice that there will be big changes in the readings, in the value for the DCI or in the IRB. So I shouldn't rely on this interpretation. But if I am totally in the let's say it's totally normal and this will it's
Mm,
changing this deactivating the sensor did not affect the results, it will be okay. But if I am in the borderline and deactivating this sensor will change the result, so
yeah.
I have to make sure that this catheter is working all the sensors.
Okay. Okay. So if you show me now again on the video, please, after like, I mean, how do you know, like you've inserted the catheter and it's in the right place?
Okay,
Uh,
so now let's say that the nurse she start inserting the catheters. So I am watching in this. I have to watch this area. You can see this area. This is the UES. I want to see this high pressure zone. I want to see this high pressure zone, and it should be within these two lines.
right.
So I asked the patient to go inside more and more and more. But for in general, the depth of the catheters generally it's like between 45 up to like 54 centimeters. It depends how much the patient he is tall. But it means I can expect what the depth. But at the same time, I ask the nurse to go down, 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 and I am giving the patient water to drink through during the insertion because this will help for the catheters to pass through the UES because once the patient starts drinking, the UES will open and then the catheter will go down. Once I see that the catheters like 35, I will ask the patient to stop drinking. Then I watch this high pressure zone in the UES. I ask the nurse to go down, insert, and I have to see that this high pressure zone now it's located in this area, and I have to see that also below. You can see here down that there is also high pressure zone, which is the LES between these two lines also. This is two lines. This is the LES border. Once I saw that this area here, this high pressure zone here, and this high pressure zone here, I asked the nurse to fix the catheters inserting and to fix the catheter at this. Then I will see how much is the depth because on the catheter there's markers. I can see
Mm,
how is the depth. Most in our cases, most of them it's like 48, 47. It's around these values. So
right.
then
Right. 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 Yeah. Yeah. Understand. Mm,
you can see then everything is okay. This is swallowing from the patients, and this is maybe this one. It's coughing. We can expect the patient to cough. This is coughing from patient.
mm,
Then once I fix the catheters, as I mentioned in the previous slide, I have to
mm,
wait like for 1 or 2 centimeters for the patient to accommodate the catheters, to
mm,
be
mm,
relaxed, to
mm.
be comfortable. So now
Yeah.
I am
Yeah.
watching these two areas. That's
Yeah.
now I'm very happy with the position. Everything is okay. But for sure,
Right.
maybe it's not always it's very clear, especially LES. UES, most of the cases we can see it's very clearly. It should be always it's high pressure. But for LES, it depends on the case because many cases we receive it's with hypotensive LES, with low pressure in the LES. So we can't see it exactly like this one. This is very typical normal, very typical normal. But most of
Mm,
cases, maybe it will be not very clear like this. So I have to just to see that there is higher pressure comparing with the channels below. And you have to know that the catheter is go to pass through the LES to the stomach. Okay.
mm,
And we have also to make sure that the catheters it's reached to the stomach by asking patient to have very strong deep breath. When the patient make deep breath, the pressure in the esophagus will decrease, and the pressure here in the LES and in the stomach will be increased. I have to ask patient for 3 times to do the deep breath for 3 times to make sure that the catheters is passed to the stomach. I will share, inshallah, next time some slides showing how it will look like when the patient make deep breath. When we discuss some real cases, we will see it how it will be very clear. You can see this is the we started do here the examination. We start as per protocol. We start with the resting pressure by pressing here. Resting pressure, it means there is no swallow. So this is the UES resting pressure. This is the UES resting pressure, and this is the LES resting pressure also. And also we can see the progression of the swallow through this animation panel. Once I give the patient a 5 ml wet swallow, the patient will start swallowing here. And here we can see the relaxation. This is the relaxation. We have to differentiate between the resting, this is resting, and this is the relaxation. And this is the progression of the swallow. And here there is also relaxation in the LES.
Right, right, right,
It's at the same time there is relaxation in the UES, and this is should be relaxation in LES, and this is the swallow. Again, this is the normal swallow. This is the normal swallow. And for sure, for if there is any problem in the relaxing here, that means we have to investigate and to know what is the diagnostic.
right.
And also we can see here, this is the low pressure, this is the break. This is transition zone. This is transition zone between the straight muscle and the muscle.
Right, right. I fully understand. So, what we can say is like now, as we look at this picture, it's like it's a lot of colors, everything. We're looking at this the peristaltic waves. Trying to try to locate the upper esophageal sphincter, which is at the top there, and the LES is lower esophageal sphincter at the bottom, and the sequential peristaltic wave between them, and
Yes.
basically, the warm colors, red, orange, that's the high pressure, as like, you're actually swallowing, and then the cooler colors, blue, green, is like the lower pressure. So first, like we're trying to, the orientation is key here, right? You need to have good orientation in like, where your sphincters are. Is the swallow being done correctly? Is the patient doing double swallow or coughing or sneezing or whatever the things that we covered in our last webinar, right? So
Yes.
only then you can actually go on to measuring the key parameters that are essential for the reading of the manometry, right?
Yes.
Yeah.
Okay.
Okay. Perfect. Yes.
This for the next things. Yes. This is the summary that what you already mentioned. What I am going to measure and to interpret it, the UAS, the esophagus in the esophagus, and the motility of the esophagus, and also for the LES. Actually, for the stomach, it's mentioned in the stomach. I am not measuring the pressure in the stomach, but the
Mm,
pressure in the stomach is very, very important for us. It is baseline pressure, especially for the IRB. So we will
mm,
discuss, inshallah, also more and more about how much it's important. I will show you in real cases if we change the position of the gastric baseline pressure, how much it will affect the IRB. And we know that IRB is the most important criteria for diagnosing the obstruction or the achalasia. Okay.
yeah, yeah. Okay. Right.
Okay.
This is a
So
very nice. This
next.
is very nice. I think it's a very nice photo that really illustrates a lot to anybody who wants uh, to have an idea about what it is that we're looking at, and So it's really like, you're looking at two sphincters and two organs here.
Yes.
They're all just as important in order to interpret the results. So this is great, Basil. Perfect. Yes,
Yes, yes.
yeah.
Again, I just mentioned here the stomach because I am not doing interpretation for the pressure in the stomach. But again, we will see how much it's important to consider the pressure in the stomach. Okay, next. Okay, so now actually this is the showing the value we are going to measure, and based on these values and numbers, we will going to make the diagnostic. We will have the DCI. This is the DCI. We will explain what is the DCI, and also we have this CDP, the deceleration point, and we have also the distal. We have this break. We have the US resting pressure, LS resting pressure, and the IRB. We will go through these parameters in the next slide. Okay, and this is again, this is the normal swell. Okay, so let's start with the DCI. It is the distal contractile integral. Actually, it's simply it's volume calculation. It's volume calculation. It's like what we are seeing here. It's like that's the mountains, ice mountains. We are measuring the height and the length and the width. This is the 3D
An iceberg, like an
dimensions,
iceberg.
and this is
Yeah.
exactly, and this is the 2D. Okay,
Mm-hmm.
and this one it's measuring the power of the contraction, how much it's strong the contraction, and based
Mm-hmm.
on this value, we will decide either it's filled peristalsis or weak peristalsis, or at the end it's ineffective motility, or let's say it's hypertensive that contraction. We will see.
Mm-hmm.
Okay. But
Mm-hmm.
there is very important point we have to highlight on it, which is the isobaric threshold. What is isobaric threshold? As you know, at the esophagus, before the patient make any swallow, there is some pressure inside the esophagus. This
Mm-hmm.
pressure, because it's that the esophagus, it's a cylindrical muscle. There is pressure inside it. Even I am not swallowing, and this pressure
Mm-hmm.
also because of the organs surrounding the esophagus. Actually,
Right.
what I am going to measure during the procedure, I am measuring the contraction of the swallow. So that means I have to detect this pressure that it's already in the esophagus. Okay. So, for example, if I want to see how much this mountain is high, it's 100 minus 20. Why? Because this is the 20. It's below the threshold line. It is exactly the same in the esophagus. So this isobaric, it's used to exclude the intrabolus pressurization and also to remove the artifacts from the vascular signal that is surrounding the esophagus. It's very important. And we will see later on in the Chicago classification, and when we are going to make evaluation for achalasia, especially the achalasia type 2, the pressurization should be done considering the isobaric threshold, it's 30, not 20. When we are going to measure the DCI, we have to make it measuring considering the isobaric, it's 20, not 30. Okay, so we have to put in our mind that there is an isobaric value, which is the threshold that we are based on it. We are doing our calculation. How we will see it on the screen. You can see in each screen, you will see here on the left bottom, this is the marker. I can change the position of this one. Now it's 20. I can change into 30 based on what I am going to measure. Okay. So
Mm-hmm.
again, so the DCR, it's volume calculation. I am measuring the space. It means the starting from the transition zone from the UES, it's ending to the EG junction.
Mm-hmm.
Okay. And also I am measuring the time, the progression of the peristalsis, starting
Mm-hmm.
also again from the wet swallow, once the patient start with swallow, and it's ending, say at after 15 seconds, or as I mentioned, we have to wait to 30 seconds to make sure that it's cleared.
Mm-hmm.
And we are measuring the amplitude, which is the pressure.
Mm-hmm.
Only the pressure above the isobaric threshold, it is considered and it's calculated. So at the end, DCI, it is distance by centimeters, multiplied by time in second, multiplied by pressure in mmHg, but you can see it's here 20. What it means that the threshold is 20. All the pressure below 20, it's not calculated. Okay? So this is the DCI. So if you just back
Yeah,
again, this is the DCI.
and in terms of so basically in simpler words, I mean, if it's low, then it's weak motility given this, and if it's high or very high, then it's hypercontractility, right?
Yes.
Yeah, yeah, yeah. Very good.
Let's, I will just we will see some example
Mm-hmm.
for how it will look like. For example, this in this case, you can see there is no pressurization at all. So this is filled peristalsis. Okay. You can see from here the swallow started from here, then there is no peristalsis. That means it's filled peristalsis. This example, this is the point the swallowing started, and there is progression, there is peristalsis, but this one it's weak peristalsis. The normal DCI should be between 450, above 450, up to 5,000, up to 8,000. And if it is between 100 and 440, 50, it is weak peristalsis. If it is below 100, it is filled peristalsis. So this one, it's weak peristalsis. It's above 450. This is an example for the filled peristalsis. The DCI is below 100. You can see this is the patient starts swallowing. There is some pressurization, but it's very weak. It is filled peristalsis. Here we can see what we
Go
call
back.
it's
Sorry,
absent.
can you go back to the weak one before that? Can you
This
go
week
back
off.
one slide? And the one before
This
that
is
was, and the one before that,
no, we
and
started from here.
this one was under 400. So this is like between 100 to 400. And the normal,
This is normal one. You can see this normal one. It's above 450.
right? But where do you
This one
see the
is
number?
normal.
Where do you see the number here?
Unfortunately, this is the screenshot, but
Yes,
usually in the software
you
we
see
can
it
see
in the
that.
bottom here, at the bottom, right? So
Yes,
you
exactly.
cannot
Yes,
really,
in
you
bottom
cannot,
the reading.
yeah. So just like for the viewer, you cannot really tell. I mean, we can tell from experience. So this is normal. But I mean, in general, for
Yes,
anybody who's doing this,
yes,
they should just adjust they should just adjust like their,
exactly. The
you know,
borders,
the
the
lines
lines.
and the
Yes,
borders and everything. And they just look at like what you get at the bottom of the screen,
yes,
right?
yes.
Yeah. Okay. Okay. Please go ahead. Now you
And
can go. Mm,
this one again. This is absent contractility. Absent contractility. There is no pressurization at all. We have
mm,
differentiate between filled peristalsis and absent contractility.
mm,
Absent contractility, there is no pressurization at all.
yeah.
Weak peristalsis, it's between below 100. The DCI will be below 100. This is just this is the absent contractility, and this is you can see the difference. Here we can see that there is the esophagus, it start to trying to have some peristalsis, but it's very weak. This is the how to differentiate. You have to differentiate between absent contractility and filled. Filled, it means that there is some pressurization. It's like below 100, maybe like 5 or 10 or 85, like this. Absent contractility, like this, no pressurization at all.
In terms of what it means to the patient clinically, right? Because we want to circle around to the patient. Doesn't matter if they have
Uh,
absent contractility or failed. Doesn't matter really. The symptoms
yes,
are the same.
yes. As per Chicago classification, the weak or filled peristalsis, it's diagnostic as ineffective motility. But we have in this classification, we have different things. It's called absent contractility. I mean, absent contractility, we shouldn't put it under the ineffective motility because you can just imagine that as we are saying it's ineffective motility, that means there is motility, but it's ineffective. But once we say that it's absent contractility, that means there is no motility at all. So this is the difference.
Okay. Uh, and in terms of like, clinically speaking, um, which one of those is more likely acquired during life, and which one of those is more likely, let's say you're congenital or something that you have some genetic propensity towards getting. I guess I guess one of the two will be more like acquired, while the other one maybe you've had it due to basically some motor neuron disease or some connective tissue disease or something like that, right?
Yes.
Uh, so like I always try to circle around like to the patients and I know the Chicago 4 like makes quite the differentiation between the two in terms of like what failed peristalsis is. If more than 50% of swallows show no
Yes.
contraction or only weak, non like transmitted contractions, right? But there's some
Yes,
residual
that's right.
activity, yeah, and that's like it's the ineffective motility, right? And this is something we see quite often. We see quite often. Most of the time when we have a pathological manometry, this is what we usually see, right?
Yes,
Well, absent contractility,
that's
that's
right.
like 100% of swallows. They have no peristaltic like vigor or
At all.
contraction.
Yes.
And it's like this DCI is under 100, and usually LES is normal. In terms of like, I
Exactly.
mean, yeah,
Yes. It's very important that what you mentioned that absent contractility you have to also to look for the IRB. It should be known because if there is
mm,
absent contractility and IRB it's abnormal, so now we are moving to the achalasia type 1. We are in different category. If there is no contractility and IRB abnormal, the threshold of 20, that means we are achalasia. But
here
in
we're
order
talking
to
that,
say
yeah,
that,
here we're talking LES is normal. So
yes,
because
yes,
I mean, so we're still not in the echalasia realm. So what I'm trying to kind of like make quite like distinguish clearly for anybody who's watching this, because really we're getting into some details that can be very that like you would have to basically listen back maybe to 5 times in order to understand what we're talking about, because it is quite difficult and technical, right? And for
yes,
gastroenterologists in general, I mean, this is not our cup of tea. That's why a lot of us don't like dealing with manometries.
yes, sure.
So I always try to kind
And
of tie it back to what this means clinically by differentiating the two. We're staying away from achalasia for now. So if we have this failed peristalsis, as we said, where you have like 50% or more than 50% of contractions are not being transmitted as they should, um, these patients
yes,
usually in general, um,
yes,
the patients in general, from my experience, they usually fluctuate in their symptoms. They'll be up and down. They usually like they sometimes feel that they have like this bolus feeling, but they can clear it. Intermittently, they may get something that feels like it's stuck. Usually, it's more common patients that have GERD-like symptoms, yes, gastroesophageal reflux disease. It's really important that people know this. We're talking about a lot of patients that may have long-standing um, reflux may end up doing a manometry, and the result would be ineffective motility. Sometimes we may get the occasional person that has some sort of connective tissue thing on like scleroderma like thing. I mean, I've only read about it. I've not seen it, honestly. And there's like the functional dysphagia, of course. And these symptoms are usually meal or probably also position dependent. Patients feel them more if they're laying down rather than they're sitting up. Well, I think if you talk about absent contractility, which is far less common,
Yes, that's
but
right. It's less. Yes.
yeah, these patients have much more profound dysphagia and regurgitation, and this is usually something that does not just come out of the blue. It's usually often connected to some sort of underlying disorder, like connective tissue disorder or some severe neuropathic injury, and the reflux symptoms can be really severe due to loss of clearance, and that can lead to quite significant esophagitis in these patients. And one thing that is very important that I'm digressing a little bit from the issue here because I'm trying to tie it back to the clinics, right? Because it's very important that we always bring it back to the patient and rather than just the technical things. One important thing is that even though when we have like the it's a state of the art like machinery and we can do these really fancy tests and we can get all of these numbers that can be very accurate. And if somebody does not know how to do this, they should bring somebody like yourself to help them to perform the test properly and interpret the results correctly. But I think something that is quite interesting in general is that what we see on manometry in terms of like the difference between these two things, ineffective motility versus absent motility, what you see on manometry does not always predict symptoms intensity. So I think that's important to know. Some patients that may have absent contractility have no symptoms.
Yes, that's right. Yes.
Mild ineffective motility disorder can have significant dysphagia. And this like probably reflects
Yes.
how I mean, this ties up to like the nervous system, like the sensation in the esophagus, probably the like the this connection between the esophagus and the stomach and the esophagogastric junction outflow function interplay, like how the esophagus and then the diaphragm and the stomach actually are working with each other to like coordinate this pretty complex physiological uh, thing that is happening continuously, but we really don't think about it because it's just happening. But it's quite complex. A lot of physiology is involved in this. So from a pathophysiologic and management standpoint, I think it's really important. Patient has absent contractility, like any physician should always be paying attention to that. This patient probably has something more advanced, more severe, and they should be looking beyond the esophagus for the cause. They should actually investigate this patient for the cause. While if a patient has ineffective motility, you should definitely exclude other pathologies, but it's very highly likely that the problem is within the esophagus stomach interplay themselves, and you need to deal with that GERD and fix it in order to improve the symptoms of the patient. We do not have an endoscopic treatment and reverse this or that can improve this. I mean, we cannot do much for this other than really symptomatic treatment, whether it's on a local level, works on on this part, or if it's some sort of neuromodulators. And point I think for kind of diet, lifestyle modifications, medications that we can use, and or we can add other adjunctive such as barium swallow in order to be more study this to get closer to the diagnosis and to always be very as clear as possible in the final diagnosis that we put in the patient's file so that that patient does not end up on an operation table, let's say for a fundoplication, but they have ineffective motility, for example, or absent contraction. because that will only make the problem worse. Do you agree with what I'm saying, or am I
Really, I'm very, very happy to hear this explaining these points because it's unfortunately for manometry, most of the cases or most of the practice, they are just focusing on just reading the report and then make the decision either medication or surgery. But very, very few physicians that are discussing the things behind the causes of that what you mentioned, the the physiology, the neurophysiology about all the that leads to swallow disorders. It's very, very important and really to understand what the cause is, why we have like absent contractility. Because if we understand very well, so we can right decision for the treatment. But if we lay on that, the report that are saying this is achalasia, for example, you say, that for achalasia, there is different options for treatment. We'll start medication and we so we can do balloon dilation. But I believe, as what you mentioned, to understand why there is achalasia, what the physiology behind, so we can make the exact and the right decision for the patients. Really, what you mentioned, it's very, very important. And to be honest with you, I rarely heard someone who is explaining all this behind the sort of disorders.
it's a work in progress. I'm still learning so much from you, Basil. So it's always I really try to get ready as much as I can for specifically our sessions, because I always feel the least comfortable. When I talk about what
Yes.
we are doing right now, maybe the only thing that would make me even less comfortable than that would be speaking about endoscopic ultrasound, maybe. But this part actually makes me quite like I always try to prepare and read as much as I can so that I don't make a fool of myself while recording. So, okay, great. Let's carry on, please. You're about to speak about IRP now.
Now it's this is also an example that you see. This is the filled. This is the filled peristalsis, and this is the normal peristalsis. That last one, because the DCI it's 830. It's above than 450. Okay, let's move to the IRB. IRB, it's the integrated relaxation pressure. Uh, I think let's move to the next slide that it explain what IRB, how the software, how we have to make the calculation for it. See. Let's see here on the top right. This is normal swallow, and here we have that the starting of the swallow, the relaxing of the UES, then the progression of the swallow. And once there is relaxation in the UES, the LES should start relaxing. There is a window. This window, it's for 10 seconds. It's fixed frame for 10 seconds. I can move the window, but it should be at the point where the UES started relaxing. But how much it's the length is 10 seconds. Okay, so the software will make calculation for the IRB within this window. Again, let's move to the left top. We have to differentiate between the resting, LES resting, and LES relaxing. Okay, LES resting and relaxing. Okay. So, how the software make the calculation for the IRB? By definition, the IRB, it's the average of the lowest relaxing pressure lasted for 4 seconds within this window of 10 seconds. It's a little bit complicated. But again, the IRB, it is the average of the lowest. You can see here, you can see this one. This is the lowest pressure. This is within the window of 10 seconds. we have here low pressure, relaxing pressure, and we have also here relaxing pressure. So the software will make for this two lowest pressure. But this lowest pressure should be for 4 seconds. We have two options. Either this 4 seconds, it is continuously like this case. So this is the lowest pressure relaxing lasted for 4 seconds, or it could be this is the maybe it's like 2 seconds here and 2 seconds here, the total 4 seconds, and the software will make averaging for both values. Or it
Right.
could be, let's say here, 1 second here, 1 second here, 1 second here, or 2 seconds. So the total will be 4 seconds.
Right.
Again, here we have 10 seconds. The software will search for the lowest relaxing pressure should be lasted for 4 seconds. This case, we have this 10-second window. The software will look for the lowest relaxing pressure. Here it lasted for 2 seconds. That it's not enough. Then the software will look for another lowest relaxing pressure for another 2 seconds. Then the software will give us the average of this lowest relaxing pressure. Okay? So here we can see how it look like. This is the window of 10 seconds. We have here relaxing, and also we have here relaxing. The software automatically will make calculation how much it's the lower relaxing pressure value. Okay. This value, it's calculated in reference to the pressure in the stomach. We can see here, this is the line measuring the pressure in the stomach. So the pressure here inside this window is in reference to this pressure.
Right.
So we have to be very careful when we put this gastric pressure in the right position. Usually it
Right.
should be below 2 centimeters from the lower border of the LES. This is the LES, the lower border. This is the upper border of the LES. So usually it's 2 centimeters below the LES. Okay?
In terms of all values here, what is it? I mean,
Okay,
elevated one means that we have
exactly.
some outflow obstruction or achalasia, right? So what is the
Yes.
cutoff?
The normal values, it's up to 20. It's
Mm,
up to 20, it's normal. Above 20, we started to either to go to achalasia if we have the other criteria, which is the pressurization, or to the outflow obstruction. Okay. So the IRB, it is one of the criteria for achalasia or for the outflow obstruction. Okay, then the next, this is the example how it's look like. This is the LES relaxing, and this is the abnormal LES. It's not relaxing. And in this example, it's a clear example for the achalasia type 1. Why? Because there is no absent contractility and no relaxing in the LES. Then the distal latency. In distal latency, we have two things. We have what we call the distal latency, and also we have this point. This is the contractile deceleration point. Actually, as it's shown here, it's very clear. This point, it's the where the slope here, it's changed. It was here quick, fast, then became here, it's become slower. This point, we call it contractile deceleration point, okay? First, we have to set this point. Then we have to measure the distal latency. Why? Because the distal latency is the distance between this point and the line where the swallow started. Okay, the swallow started from here. So this is the vertical line, and this is the contractile deceleration point. So this is the distal latency. So what the indication it's used for distal latency? It should be above 4.5, above 4.5 seconds. If it is below 4.5 seconds, it means we have premature swallow. We have
Mhm.
premature swallow. This is like an example. We can see this is the normal swallow. This is the distal latency, it's 7.5. This is the deceleration point. And we have here abnormal. We can see that this is the deceleration point, and we can see here that the distal latency is 4.3 second. Okay. So
Mm.
distal latency, it could be, if it's abnormal, it could be one criteria of the distal esophageal spasm, and if it's the IRB, it's normal. If the IRB is abnormal and there is the distal latency, it's abnormal, now we can talk about the achalasia type 3. So, Doctor, just here, I just mentioned that in the previous, there was what it's called diffuse esophageal spasm, but this is not used anymore. Now it's the distal esophageal spasm. This is the current definition. I mentioned here because if anyone he read some literatures, it's all literatures. Maybe he will find that it's mentioned diffuse esophageal spasm. This is just to differentiate. That's all.
A lot of information for people
Yes.
to think about. Um, and it's not easy. I think and I'm happy that we're dividing this into multiple sessions so that we can always revisit different aspects of those tests. And we both understand that this is most people will not be dealing with this. But I think
Yes.
a lot of these issues they just go underdiagnosed for a very, very long time. And they cause a lot of
Yes.
morbidity and worsened life quality for the patients. So I think by spreading the knowledge about, just to increase the index of suspicion for those disorders and to enable more people to make at least the basic readings for these complex methods, I think we can really help many patients. And I think this is the idea behind everything that we're doing here at the academy. We're just trying to deconstruct and to break complex things and ideas down into simpler, reproducible steps so that everybody who is interested in improving their knowledge, learning something new, they can actually do it in a safe environment to do it at their own pace. And then if we succeed in pitching this idea
Yeah.
to some of our colleagues out there, then we have definitely succeeded in our project. So thank you, Vasil, very much for another
Thank
excellent
you.
session. This was
Thank you,
really
Dr. Osman.
wonderful. I'm always learning a lot from you when you are visiting us in the unit to help us with some of our procedures. But I learn even more when I start getting ready for our talks, and then when I hear you explain things in that depth and in that detail. You really master your craft, and I have big respect for that. So
Thank you
by
very
by
much.
so by understanding, like, so if we just wrap here, by understanding the equipment and the meaning behind the parameters that we're dealing with, DCI, D and DL, and all of these, see, like, it can like kind of bridge this gap between what's technical and what is clinical, and this kind of lays some sort of a groundwork for accurate diagnosis for these functional disorders. So thank you very much for your time today. I really look forward to our next session week, inshallah,
Um,
where we'll
yes.
be going more in depth about, like, these different pathologies, what they look like, manometry, and we will definitely touch up therapies, the therapeutic options for each one of those pathologies. And
Yes.
finally, we will move on to the other aspect of this, which is pH monitoring and impedance. Thank you again very much. I really look forward
Thank you very much,
to
Dr. Samir. Thank you for your time. Thank you very
thank
much.
you. Thank you. And
Thank you.
have a great evening. Thank you. Bye-bye.
Thank you very much. Thank you, Doctor. See you.
Bye.
Bye bye.